Hi, John.
Gabby, how you doing?
Good. How are you?
Good, good. You like his background?
Huh?
You like the background?
It's the same one or you changed it?
That's Miami Beach.
Yeah.
But yeah, you're on the water in Mumbai, right?
Yeah. We are
Out
close
of
to the water. Yes.
nice
We have
beaches,
beaches. Yeah, we have beaches.
the nice ones.
Mm.
Goa, right? Goa.
Goa has nicer ones. Yeah.
That's south. That's south, right?
Yeah, that's a little south.
It's
Not too far
long.
from here. Not too far from
It's
Mumbai.
a long bike ride.
No, it's not. Bike ride is 24 hours, maybe. So short plane ride, 1 hour.
Yeah,
Uh,
yeah. We won't get as many people because week here is like
Yeah.
week, but that's fine. That's fine.
Yeah, that's fine.
That's fine. I've seen Atul lecture to two people one
Yeah.
time
Yeah.
a while ago when I was in Nepal.
Yeah.
He did
Dr. Arshad
almost a
is
complete hour. He almost did an hour with
Yeah.
the two residents. I don't know if they realized how lucky they were. Really, they didn't. I was amazed too. And you know who else is like that? Roberto Herrera.
Okay.
He's an Argentinian. He'll do a webcast if there's one person there. Because I said, look, I don't want to keep you here. But he says, no, let's go ahead and do it.
Okay.
So you've been going to conferences? You know what I'm going to try to do, Abby,
What?
is use just an experiment. Have
Mhm.
someone in the audience, like hopefully a neurosurgeon, that can comment in the chat while Azul's talking. It won't interrupt anything. It'll just be like a side thing of comments. What do you think? Think it'll work?
Regarding the lecture, huh?
Yeah, yeah. While it's going on, someone commenting live, mentioning something about it. It's- I'm not asking your permission. I'm gonna do it.
All right, do it.
Hey, Arshad.
Hi, John.
Uh,
Hi,
uh,
Dr.
Good
Arshad.
morning.
Good
Hi,
morning.
Avida.
Hi, Dr. Arshad.
Hi, how are you?
Good.
You're in the
Good, good,
hospital. In
good.
the hospital, right?
I'm in my consulting room, the clinic there.
Or would you like to moderate, Harshad?
Avida is there.
Yeah, could you?
I
You're
can
well
do it.
dressed and everything.
Yeah,
You
Dress
do
for
it,
yeah.
sir.
me.
You do it,
Yeah,
sir. You do
yeah. Yeah, yeah. I'll go talk to you. Yeah.
Okay, so you'll moderate and introduce a tool, right?
Yeah.
Okay. You've done it before. You know what you're doing.
Yes, yes, yes.
I've been having a lot of Indian neurosurgery students and residents. They've been watching this. They've been contacting me, and I told them, I says, what you need to do is go to webcasts and comment, not extensively, but just say, I'm John Bennett from Miami Beach, studying to be a neurosurgeon. Nice to meet you. That's all I need to say. The king must have run into traffic.
No, I think he should be here soon.
You take the elephant to work today?
Huh?
Did you take the elephant to work today?
No, we took the car today.
You opted for the car.
Yeah, the elephant is taking a rest today.
No, when I come back to India, I want to see Bengal tigers and elephants.
When are you coming? You should
I
come
don't
next
know.
year
Yeah, I would love
next
to.
year for our conference.
Oh, when is that?
July 31st, 1st, 2nd, 3rd August. You should come, John.
Maybe. I liked it there. I didn't spend much time in India. I was in Nepal for 3 months. So,
Okay.
but I imagine it's very similar, the food and stuff. It varies, I guess. But
More
I did.
choices.
What's that?
You'll have more choices of food. Yeah.
No, I don't know Indian food at all. I know the smell of curry. That's something you don't forget.
Yeah.
When you smell it, you know, oh, there's Indian food. I know there's a lot of people in this country that love it. There's a lot of Indian restaurants.
Yeah.
Not as many as Italian, and a lot of Italian here in this country. And of course, Chinese is very popular. Chinese and Italian, very popular. Everywhere you go, even in the small villages, with Chinese food.
Okay.
But it's going to get harder to come in the country now. Apparently, it was difficult before, and now it's going to get even more. What's your opinion of Trump?
Don't ask controversial questions on the live webcast, John.
That's true. You're right. Yeah. Well, there's a lot of funny things.
Yeah.
I'm not talking serious political issues, but even
Somebody
that.
needs to see his brain.
What's
Yeah.
that?
Somebody needs to see his brain.
Is he going to talk? He's welcome to talk as long as he wants. But
Yeah.
does he plan to talk a couple hours or 1 hour, hour and a half?
Maybe hour and a half. I'm not sure.
There's no limit.
Yeah. Let me just check where he is. Okay.
So, Harshad, you've been busy.
Not very busy, but yeah, yes, every day working, something or other is going on, some work, some surgery. So keeps you running around busy. Nothing
Are
much.
you, are you do you operate a couple of days a week or every day or?
It depends on a number of cases available to you, and mostly 4 or 5 days in a week, it happens.
Really? Like for how
Yeah.
long? Well, you never can tell, I know, but 4 or 5 hours at
Yeah.
least.
3 to 4 hours. Now, I'm not as fast as Atul, but yeah, not very slow too.
Yeah.
Occasionally, yeah.
So it's dependent upon speed, huh?
Yeah.
Have you seen any change in what's offered in the operating room lately or no?
Not really. The various I visit various hospitals, you see, and every hospital has got different kind of facilities.
Yeah,
And yeah, but
basic
things are
stuff.
changing. Yeah, yeah. I go to 4 or 5 hospitals and we operate at different places and we find different changes.
So you get as much work as you want.
Yeah, we learn more from this webinars and meetings and conferences, reading everything, and plus our own experiences teaches us how to become a good surgeon.
Yeah. So a lot
Yeah,
of interest.
he's joining in 2-3 minutes. He's joining.
Okay. So the in-hospital conferences, they have like grand rounds.
Grand rounds are there, but not grand as they are called grand. They're just rounds. The
Just
residents are
rounds.
there. So,
Oh, okay.
yeah,
So they
yeah.
go over cases in the hospital that occurred. Yeah, I've been trying to get people to broadcast the grand rounds, but so far
Yes.
I've had no luck because of privacy, I guess, and security. And I guess, it's just a pain, I guess, but no takers so far. Although we did televise the tool, his live surgery, one whole night, one whole day, live.
Yes. I think Atul has joined, make him panelist.
Oh, you just did.
I
How'd you?
see him. I saw his name.
Oh, okay. Oh, you can see that, huh?
Yeah, attendee's name.
Hello, John.
Hey, Atul, how you doing?
I'm very well, John. I'm sorry I had some, little bit confusion regarding the time.
Yeah, that's okay. Okay, you can go as long as you want, Atul. So,
Yeah, I'm ready now, John. You can maybe, I think let's begin now, whatever is the thing.
well, yeah, here it's a week during the week, and so most neurosurgeons will be in the hospital. It's probably the
Yeah.
same in India too, right? But it's a
Yeah.
nighttime in India, right? So
This is-
you'll have, yeah, okay.
Whatever is there, let's do it. Okay, John?
You ready to start? Okay, here we go.
Okay.
10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good evening, good morning from Miami Beach. This is John Bennett, home of Neurosurgical TV. We are honored with the presence of the King, and we call him the King because he goes to all parts of the world and educates both by publication and lately with Zoom. I guess he took to Zoom pretty early, and he's going to give a presentation on my spine surgery book. And let me have a neurosurgeon introduce you properly. Harshad, could you introduce the King, please?
Yes, John. Thank you very much, and good morning to you, and good evening, and good afternoon, everyone. It's my privilege and honor to be part of this journey of my good friend, colleague, and he's my mentor, and whatever all adjectives I can add in the world under the roof is Professor Atul Goel, who is going to take us through his journey of the spine. We had a fantastic evening on Sunday when he took us through the journey of brain. And I have no doubt about it. We will be all enthralled and enlightened by his experience, hard work, and all the teachings which he's going to do, all of us. It's privilege to be part of it. Those who could not, they will miss it, and I'm sure they will be able to see on your neurosurgical TV as a recorded video. It's worth being investing your time in with Professor Atul Goel. Yes, Atul, it's your turn. Go ahead.
Okay, Harshad. Okay,
Floor is.
Harshad. Thank you, Harshad, and thank you, John, for having this session. I know that today is a little bit of a busy working day. So I can imagine, but whatever said and done, I wish to present my thoughts on spine, my journey of spine, and my life in spine. Although this many of you and most of you have heard me several times, but there is no question in my mind. Some of these thoughts, some of these ideas can be and are complete game changers, complete revolution in spine surgery in general and craniovertebral junction surgery in particular. So let me see. I will just try to summarize the thoughts. I know many of you have heard them, and many of you follow them also to an extent, particularly in craniovertebral junction. But whatever said and done, let me see what I can show you. So this is what I call towards a spinal surgery revolution. So this revolution you have seen. So basic thought of my work is that neural compression, whenever you talk to any spine surgeon or anyone who deals with, whether it is a neurosurgeon, whether it is an orthopedic surgeon, you talk of compression. So my concept for a very long time is that compression is not the cause of neurological symptoms. Compression is not the issue. The problem is somewhere else. Compression is seen on imaging. We try to treat the imaging, which is not such a correct idea. And most important is neural decompression is not the treatment. So this is the basic premise, and I will like to elaborate on this a little while later. First and foremost is I want to give you my thoughts on the most beautiful disc that you are seeing. Intervertebral disc that we call is the mother of spine. Do you know that first thing in embryological parlance, when whatever is born first is the disc, and from that disc, the whole spine develops. So disc comes first, and everything in the spine comes later. So disc is the mother of spine. If I say that disc is the mother of vertebra, it is not wrong. The disc gives influence to the vertebra as to how it to be formed and what is to be done. So this is the earliest in the embryology to be formed, and it is the mother of spine. So this we had written a beautiful prayer regarding what is the intervertebral disc, and I wish that you read this prayer of mine. 4D reverie. Reverie means reverential or praying. So this I wish that you can read this article. Most important thing that we have to know is that water is life and life is water. From every drop of water, the life emerges. And if there is no, why we make our journey to the moon, to the Mars in search of water, because wherever we see water, there will be life. And without water, there is no life. So nature plays with membranes and with fluids to make the human body. It plays with membranes. Membranes are also very early in the embryonic life. First comes fluid, then comes periosteum or pericranium, and then comes the bones. So fluid comes first, membrane comes second, and then come the bone. So this is the sequence of events. So if you see embryo, this is a fetus of 16 or 17 months old fetus. You see this fetus. Now in this fetus, you will see there is nose, there is ear, there are fingers, there are toes, there are legs, there is body here. But can you believe there is no bone in this fetus? There is disc, there are vertebral artery, there is carotid artery, there is all kinds of arteries, and heart is there, but there is no bone. So bone formation is actually much later in embryonic life. Fluid comes first, disc comes first, bones come later. So if you see this embryo at about 20 or 25 weeks, then the bones, this is bony vertebrae come in picture. And these bony vertebrae come later in the embryonic life. First, there is ocean of fluids, and bony vertebrae come as discrete islands in an uninterrupted ocean of soft tissues. So there is an ocean of soft tissue, and vertebral bones are then coming in picture. You see the femur is coming, the vertebrae are coming, and things like that. So it is not, the skull is formed later, brain is formed first. So skull is almost like a cap, is like a cap. It is like a cosmesis more than a real functioning. Bones do not give protection. If bones were for to give protection, there should be bone in front of the eyes. There should be bone in front of the pregnant lady's stomach. So it is, bones are an afterthought of nature. Bones come later. Bone is the weakest part of the spine. Disc is the strongest part of the spine. Skull is like a cap, like vertebra is like a bra or a bangles. They are like bangles. They come on the spinal cord, and they come much later in the embryonic life. The disc comes first. So to say that spinal cord does not pass through the foramen magnum, it is the foramen magnum which develops around the existing nerve. Similarly, mandibular nerve, we should not say mandibular nerve is passing through foramen ovale. What is foramen ovale is fashioned around later in the embryonic life, around the mandibular nerve. Now you see this astronaut. Astronaut is almost like floating in air, like a fetus. I like to call the fetus as amnionaut because it floats in the amniotic fluids. You know, if this fetus can be 2.5, 3 kilogram of weight, but you will find the pregnant lady moving around, jumping around all over the place because this fetus is floating, and this floating makes the fetus weightless. And that is why this person is able to walk and run with a very mature kind of fetus. Now, why the brain is weightless? Brain is 1.5 kilogram weight. When I sit, do I feel that weight? Why I do not feel that weight? Because there is CSF around, there is fluid around the brain. There is fluid around the brain. Imagine if you do lumbar puncture, why there is headache and why we ask the person to lie down? Because when there is no fluid here, the brain touches the base of the skull and there can be pain. That is why we say, okay, you lie down for a period of 24 hours and only then you get up. Because this fluid is making the brain weightless. That is very important. So brain normally weighs about 1,400 grams, but in the water bath of CSF, it has the brain weight of only 50 grams. So that is such a beautiful thing. Other thing is, all the muscles of the human body are focused on the back of the spine. So this divine structure, the disc, there is no muscle in front of the disc. Let me show you. So when we stand, when a human body stands, we stand on fluids. So there is fluid in the joint space, fluid under the heel, there is fat, which is fluid. Under the hip joint, there is fluid. Under the eyelid, there is fluid. So all movements of the body, are on fluids. We must remember, even the spine, why I can turn like that and why I can dance, why I can jump, because of fluids. So why my whole body, which is weighing whatever kilograms, I feel weightless? Because I am not standing on bone over bone. I am standing on fluid, which keeps me floating and weightless. It is such an clinically important concept. If you go more in this, many of my articles are based on these basic issues, which really nobody has ever studied or understood these concepts. So we stand fluid on fluid. And if this fluid, like in knee joint, why it pains and you put artificial disc? Because when you walk or don't use your knee properly, there is loss of fluid and there can be pain. Similarly, in the intervertebral disc, when the fluid becomes less and the bone touches and instability happens, that is the point where bone touches the bone and there is pain. So it is so important to have your fluids in check and your fluids. So this intervertebral disc, we should not call it intervertebral disc, we should call interdiscal body. Because disc comes first, body comes later. So we should say interdiscal body, not intervertebral disc. This is a misnomer. So this is the disc like a car tire. And this nucleus pulposus is the air in the car tire, and annulus fibrosus is the rubber of the car tire. This rubber keeps the fluid intact and in a closed compartment. And this rubber, this fluid has to be in a proper volume for it to be functioning. Most important is in nature. Functional necessity, whatever we need to work, the nature manufactures the body in that manner. So it functional necessity, if we need to, a four-legged animal has a different structure, birds have a different structure, human body has a different structure. So according to the function, the body is manufactured in a different fashion, and this innovation of the nature is important, and these innovations are secondary to functional necessities. So what essential is all living beings are differentiated from non-living being by movement, and this music of movement is the most important. And even hydra, even amoeba, everything moves. If it is not moving, it is a dead organism. So music of movement is the issue. Now I will show you some animals. This is a snake. You know how the snake has to turn and twist and all those things. So this is a ball and socket joint of the vertebra. You see this vertebra, and this is a socket, and this is a vertebral body, which is like a socket, ball and socket joint. And in between the joint, there is fluid. So this fluid makes it turn and twist and manipulate the whole body. This is a millipede. Millipede has no bones. So, and it can turn completely. So the essential lesson is the movements are caused by the disc. The movements are a result of a disc and soft tissue. Bones do not cause movement. You see the vertebra, this word vertebra has come from a Sanskrit word. Vertebra means parivartan, means change, which is a misnomer because vertebra is a fixed thing. It does not change. On the other hand, fluid changes. So most important is this fluid, these movements are a result of fluids. You see, this is an X-ray of a cat. Have you seen cat walk? Cat walks with a very stiff kind of a walk. Cat walk in a female, when you see cat walk, they walk more on the hips rather than on the spine because the bones are more and the fluid is less. That is why cat does not move the spine too much. Cat walk is a very important walk for a stylish person. So this is an aeroplane. I want to ask you how many of you know which is the strongest part of the aeroplane. It is not the nose of the aeroplane. It is not the tail. It is not the wings. It is the tires. It is the tire. So if the plane happens to land on the wings, it will be blown off into millions of pieces. If the plane happens to land on the nose, it will burn off immediately. But the plane lands on the tires, which have a column of air. So the air is like a disc. Your car cannot run for more than 2 meters if there is no air in the car tires. So if this plane lands on the air of the tires, it will land safely. The strongest part of the aeroplane is the car tire. Strongest part of the car is the air in the tire. Strongest part of the human body is the disc. But if you must realize that for the plane to move, there should be petrol, there should be motor which moves the petrol, there is a motor. So that motor moves the aeroplane or motor moves the car, but the car has to stand on the air. So air does not move the car. It is the motor which moves the car. So the muscles are the human motor. Muscles move like a petrol, and disc is like a air in the car tire. So we can make these movements, we can turn and twist our neck because we are having our disc or fluids. You see, this lady can put one toe of the foot and stand. Why she is able to stand? Because there is fluid all over the place and she can make herself weightless and can dance and twist. So similarly, the neck is twisting because of the disc. So disc is a dynamic structure. Disc vertebral. This is the bone are the children of mother disc. Disc comes first, bones come later. But there is to be motor, and that motor is the muscles. And those muscles are acting on the facets, not on the disc. Like on the car tire, have you seen any motor on the car tire? Motor is far away from the car tire. Similarly, the muscles are acting on the facets, not on the disc. So this is a very important correlation. So the fluidity of the body has to be understood in a very right and beautiful perspective. Now you see this is a four-legged horse. Basically, the pressure on the spine is not too much. The pressure on the elbow and the hip is because the person has to stand and walk and run, and strong shoulders and hip joint is necessary. So this is the beautiful animal. The spine is not so mobile. So if the spine is not mobile, the disc spaces are small. Now you see this is the craniovertebral junction of a horse. Can you see the movements have to be so big of the neck? This is the odontoid process. You see the odontoid process like a U. And these are the big, large facets. So this U-shaped odontoid process is characteristic of herbivorous animal. And you see the spinous process of C2 is so big, the transverse process of the atlas are so big because of the muscles which keep the movements. And if you see this one, this is the joint of C0, C1 joint. You see how deep is the C0, C1 joint, how big are the facets. And so this is a special craniovertebral junction of a horse. Now deer, deer, the eye is lateral and the deer moves the neck very much on almost 180 degree or more is the movement of the head of the deer. Now you see this is the odontoid process of the deer and how round and circular this odontoid process is. See the flat facet articulation, see the round facetal articulation of the C2. You see this is C2, this is the odontoid process round. And this is a characteristic of herbivorous animal, round, and the facets are big because the movements are big. So the functional necessity is the mother of structural innovation. Now this tiger is herbivorous animal, is a carnivorous animal. And human being is also by nature a carnivorous animal. Now you see, this is the beautiful, now you see this one, what a fantastic handsome face this animal has. See the mandible is so big. You see this tooth is almost going in the eyeball. You see this tooth is so strong, is almost touching the eyeball. You see here our tooth is very small, but the tooth of the lion is going right up till the eyeball because the tooth crushes the bones of the animal. See this zygomatic process? Now you see the flat zygomatic the muscle, the temporalis muscle in a lion are like steel wires. They have the power to crush the bones of a deer, of any animal. They can just crush. So now you see this is the craniovertebral junction of a lion. See the odontoid process like a human odontoid process. See the facets are not very big, not so big like a horse's facets or the deer's facet. See these facets are almost like human facets or little bit larger, but not too much like a human. So these are the facets of various animals. This is of the horse. This is of a deer. This is of a lion. You see the lion, see the muscles, how the muscles are attached and how it has the power to break the bone. And this is the human. So this is just I'm showing because we have written several articles on this subject about why and what of bones of craniovertebral junction. I'm sure if you want to read, you can read them. Another beautiful thing is this bird. Do you know the bird can move the head 360 degrees? Complete 360 degrees. Do you know how it can move 360 degrees? You know, when the if you go to the one who cuts the chicken and cuts the head of the chicken and gets the muscles out, he has to just rotate the head completely. So because of more movements, the stability is less. You cannot turn the head of a lion, but you can turn the head because it is so much mobile. Now you will ask me why it is mobile. You see here, there is a beautiful craniovertebral junction. This is the C2, there is odontoid process, and there is one body here. This body is aligned with the body of the anti-arch of Atlas is like a body of Atlas, unlike human body or tiger body where there is an arch of Atlas. But in a bird, there is only one condyle, You see, one condyle. One C1 body, and this is C2 body. The facets here are small. This is odontoid process. That is why the bird can, if there are two condyles, they cannot do 360 degrees. But there is one condyle and one C1. That is why the bird can turn 360. So that's a beautiful. Another beautiful thing that we have to understand is the odontoid process. Odontoid process is a magical body. Now, I have written several articles on this subject. Like odontoid process is like a disc, intervertebral disc, and odontoid process have similar function. Disc is like a brain of the movement, brain. But the brawn means muscles. The muscles are different, brain is different. Disc is the brain of movement. Similarly, odontoid process is like a brain of all the craniovertebral junction movement. You will ask me why. Now you see this poor man driving this rickshaw. You see, he's not so strong to pull up 5 people sitting here. He's not so strong. But what is the beauty of this make of this rickshaw? You see, these are the huge wheels, and the weight on the handle is very less. But he holds the handle and can run. He's not like a big, mega muscular man. He's a weak, poor man, but he can lift several weights. And this is but if he is not there, the rickshaw cannot move. So he is the brain of the movement, but the power of the movement is the make of this rickshaw. So that is the design of the craniovertebral junction, the large facets, and the odontoid process is the brain. So that is some beautiful thing that you will like to know. So disc and the odontoid process, there is no muscle attached to the disc, and there is no muscle attached to the odontoid process, but they are like opera conductors. They can move the whole opera without having any muscle in the hand or any instrument in the hand. And these are a lot of philosophical implications, but believe me or not, this information has too much of clinical implication, and that is what we have to learn and understand. So there are several articles of mine which no neurosurgeon has ever read and no neurosurgeon is ever interested. But you have to, some beautiful concepts which are the mother concepts. And I have to tell you that my journey through spine surgery is through these concepts. Like you see, the muscle is an eco-friendly automobile. Then there is foramen fallacy, then equalization, neuraxial healing, and all these things are absolute beautiful articles and many more. I have got several articles on this philosophy-based subject. Now I will talk on surgery of the spine. As I have mentioned to you on many previous occasions, now whatever will be there, most of you have heard me several times, but still enjoyed that I have to say that anterior surgery I was doing very frequently and very commonly. This was my operation. And this kind of corpectomies and anterior surgery was very common in my neurosurgical armamentarium. So this kind of plate and screws or whatever is very well known, like Casper plates and all those things we know, and this screw. But what I had described is, and which is very frequently now adopted, is tricortical method of screw implantation for anterior cervical. This I had described in 1993. So many years, more than 30 years ago, you can see this was my article. And this is another paper, tricortical interbody fixation. Now you see here, tricortical means one cortex is here, one cortex is here, and transdiscal, and it is holding the other cortex. And this is the plate, this is tricortical. So this is what we have described, this transdiscal screws for the first time in the literature. And believe me, they are very strong and many people now use it. So this surface, this discal surface of the body, we described the use for the first time. Otherwise, always anterior body and posterior body and bicortical and all those screws. So you see this screw is going tricortical, this is going bicortical. Now you see here, only screws. One screw is going transcortical in this and one screw is going, there is no plate, and this is a beautiful solid fixation. You can use one screw at each strong level, and this can also be a strong anterior fixation. This you can do like this. Now here you see there are three screws, 1, 2, 3, three in a transarticular fashion, and there is some bone graft. You must remember that this was a beautiful kind of innovation which was several decades ago, but this has its own relevance. From here generated many new implants that we have seen. Many people talk of disc and then they use this kind of implants which are very common, but the origin of these implants were from this information of this idea. So you can have multiple plate and screws, and some screws tricortical, some bicortical, and things like that. Now I will show you another technique which I described is vascularized pedicle laminoplasty. Vascularized pedicle laminoplasty. So you make a cut around the lamina and elevate the whole lamina like this, and elevate the whole lamina behind, and then after the surgery you replace the lamina back. So this is, I call it vascularized pedicle laminoplasty. Another thing that we described is thoracic laminoplasty, using, you make a cut at the base of the spinous process, you make a cut at the base of the spinous process and place them parallel at the end of operation, and you can have, you see this is after few months these have become like a solid bone, so laminoplasty. Another thing that we described is interbody fusion after spinal tumor resection. So this is the tumor, you remove this tumor. As soon as you remove the tumor, you see the interbody, these vertebral bodies, and you can put a plate directly. This we had described some 30 years ago, and some people have followed it. Some people have tried to make some different modification, but this is the technique that I described in 1992 or 93. So now I go to craniovertebral junction. I will very rapidly try to show you what I have shown on several occasions. Craniovertebral junction has been one of my foremost and one of my most loved subject for a very long time. And this is difficult, this is dangerous. You have to know the anatomy, you have to know the technique, and you have to know the technique of hemostasis, and everything, it has to be perfect. And these are the two beautiful bones of human body. Unlike the horse and animal, the facets are the little bit smaller. Odontoid process is like a carnivorous animal. These are the strongest facets of the body, C1 and C2. Largest transverse process of the spine, largest spinous process, and this bone, which is the brain of movement, or like a disc. So anterior surgery for anterior compression was the norm several years ago. Everybody used to do transoral. Wherever there was a compression, that compression had to be removed. So compression was the issue, and anterior surgery was there for decompression. And I also was doing this decompression by transoral route for several years. So remove the odontoid process and then put, this is what I described. This was the first article in the literature where metal implants were described from the mouth and from a transoral surgery. And this was a very solid kind of fixation. In 1992, I did this transoral and from clivus to C2. And this was actually retropharyngeal surgery. behind, which was not through the transoral surgery. I also did transoral, you see, in this kind of thing. I removed the whole odontoid process and then put a big iliac crest bone. But then we developed this C1, direct C1 fixation, direct C2 screw, and this plate and this technique has then picked up in the whole world. I described it in 1987 when I was 27-year-old, and then it has really picked up like absolute. The whole world is doing this. So these are the strongest part of the spine. These facets are strong, and if you are able to put your screw, the grip of the screw is very fantastic. The technique of mine involves opening of the joint, introducing bone graft, and then doing metal bone chips inside. Remove the cartilage, put bone chips, and then do the fixation. This is a very strong technique. Many people in the world still like to do occipito-cervical fixation. So this occipito-cervical fixation we were doing, and we were very good in it. And actually, I described introducing screws here. For the first time, we used screws in 1987. But as you know, over the years, I have complete belief that craniovertebral junction instability means atlantoaxial instability. Craniovertebral junction stabilization means atlantoaxial stabilization. Very rarely we need occipito-cervical fixation in syndromic children in high degree of trauma, and sometimes in tumor cases. But essentially, is occipital fixation necessary? My answer to that question is it is not necessary. It is suboptimal kind of fixation, and it may be counter-effective. So essentially, when you have to do C1, C2 fixation, you have to do C1, C2 fixation. You cannot do occipital, which is not such a great. You destroy several movements of the head, and also you make the implant a little bit long and poor stability. Longer the implant, poorer the stability. So this was my first case in 1988. Many of you know it, and many of you have heard about it. C2 ganglion is the key to this area, and we described that if you remove the C2 ganglion, you can expose the joint. This was a very small little anatomical tip, but this small little anatomy has the potential to completely change this area. It is a window to the atlantoaxial joint, cut the ganglion. But nowadays, as many of you have heard me several times, that I don't cut the ganglion. Other important thing is in this area is the vertebral artery. We have to know the vertebral artery. Sometimes it can go very deep inside, and this anatomy has to be learned on cadaver. When we used to in 1984, 85, all the time we were sitting in the cadaver lab whole day and whole night. And there this article was written during those days, and this was a beautiful. So in 1988, we divided C2 into 9 quadrants, and we said that C2 screw you have to put, because the vertebral artery is in relationship. You see, if you see the vertebral artery comes like this and goes in the facet of C2, and then it turns back. So in this article, we had written that this vertebral artery has a dynamic kind of, it moves on flexion extension, there is movement, and in rotation. And if there was no loop, you could not have this movement. So when you turn, the artery goes inside. So this vertebral artery groove is for the movements, and these are normally occupied by venous structure. Because the vertebral artery is relationship with the C2 pedicle, you have to be very medial and very superior in C2 screw, and you have to know the vertebral artery very nicely. So this is the direction, superior and medial. You can use neuronavigation, but if you have the anatomical concepts correct, you may not need it, but it may be advisable for those who have not, much experience. So this is the vertebral artery, which forms the key to the craniovertebral junction surgery. So because to decipher that 3D, decipher that vertebral artery anatomy, we made these 3D models for the first time in the literature. Imagine from India, which is technologically may not be that much known, but we use this technology in developing this. So this is a 3D model. This is an anomalous vertebral artery. which we identified on 3D. This is also anomalous vertebral artery, but these models made us, you see, this is also anomalous vertebral artery. So you identify the vertebral artery and then you make this C1, C2 screws. This was the trick. You see the hole in the vertebral artery. So if you have a 3D model like this, you can exactly know how to put and where to put and which area has to be avoided for this. I don't use these models very often now probably because of our experience, but I will recommend for all those who are doing. Another beautiful thing of craniovertebral junction is the C2 vertebra, which is a beautiful bone, is normally the superior facet and inferior facet are in one line. But in C2, the superior facet is anterior and inferior facet is posterior. So if there is a problem of putting the screw in the superior facet, you can use the inferior facet. So we describe this inferior facetal screw or inferior C2 3 screws for this fixation when there was high vertebral artery. Like in this case, you see the vertebral artery is very high. You see vertebral artery is very high. So I have used C2 inferior facetal screws. You can also mobilize the vertebral artery. The bones are like here. We describe this mobilization, drill the posterior surface and mobilize the vertebral artery, and it is possible, and then use the C2 screw. Here, if you see the bone is thin, you can drill it and push it down. You see here, the vertebral artery is pushed down, and then you can do the screw. This is also, you have to understand and you have to do whatever you have to do. So C2 we also described, sometimes it is difficult, so we use the spinous process, we use the lamina, we use the spinolaminar line for fixation of the C2 vertebra. You see here C2, I don't use these things now, but we had described for the first time about 30 years ago, screw in the spinous process. We also described intra-articular spacers for the C1, C2 fixation several years ago. We called it joint jamming technique, and this technique has a standalone, you can do fixation. Sometimes, as I mentioned, I now like to do occipital. I don't like to include occipital bone in the fixation construct. Sometimes in assimilation of atlas, C1 facet is quite up. So I have described, remove some occipital bone from here and then extradurally expose this. So transcranial insertion of the atlas facet screw is possible. Most important revolution in craniovertebral junction was when we identified that there is nothing like fixed dislocation. They are mobile, they are unstable, they are pathologically mobile, and they are not fixed. And you can open the joint, manipulate the facet, and do reduction or fill this. This was a complete revolution in craniovertebral junction surgery, which we described in 2005. So this kind of patients were all treated by transoral surgery, but open the joint, manipulate the facet, reduce the dislocation. This understanding was it completely changed the craniovertebral junction. Now, not many people in the world are doing transoral decompression. Still here and there, I see people talking about decompression, but I have to tell you that I have completely abandoned transoral decompression for a very long time. Even when there is fascial disruption, open the joint, learn the art of manipulation, the facet. Otherwise, the only treatment here was decompression. Rotatory dislocation, nobody knew how to do rotatory dislocation. So we introduced the concept that open the joint, manipulate the facet, and reduce the dislocation. The neck will become long, the neck will become straight, and you can have a normal person. Also, when there is limb problem, you can have improvement in the limb function. Basilar invagination is a very common subject which craniovertebral junction, those who are doing craniovertebral junction talk about it. So basilar invagination in 1998, we have divided into two groups, odontoid going up and tonsil coming down. Here we said in 1998 that this needs decompression, both need decompression. This one needs transoral decompression. This one needs foramen magnum decompression. So this was what I had described decompression. And here we said that the posterior fossa is tight. That is why you do bone decompression. But in 2004, we changed, and this kind of lecture, you will be surprised to hear from me that I have given more than 250 times this lecture in the last 30 years of my life. So many times I have repeated, and many of you who are watching me have heard this. So this in 2004, we said that this group is unstable. You open the joint and reduce this dislocation. But in 2004, we said that this group needs decompression. So this group is unstable. This was stable. This was my concept in 2004. And we introduced the concept of realignment. For this kind of basilar invagination, the whole world was doing transoral decompression, open the joint, distract the facet, and reduce the dislocation. And this completely changed the whole world of craniovertebral junction and of basilar invagination. No, decompression is not the treatment, and stabilization is the treatment. Another now recent thing, which is complete, in my view, a complete revolution in craniovertebral junction, is the concept of central instability or chronic instability. Is the mother of Chiari and syringomalia and several other things. So chronic instability is the mother or the father of all these things which are mentioned here and many more. So all these things are secondary to instability. They are naturally protective or adaptive, and they are potentially reversible after the father is treated. So sometimes this father can have two children like Chiari and Syrinx, or three children, Chiari, syringomalia, or basilar invagination. Sometimes this cat can have only one child like basilar invagination, or only one child like syringomalia, but the father has to be treated. And these are not pathologies, these are protective. The whole world thinks they are pathology. Whole world treats them by decompression. So for the first time, we said that instability is the problem and stabilization is the treatment. In 1999, we said that like lumbosacral listhesis, C1 over C2 listhesis is the problem. This is unstable, basilar invagination is unstable, you stabilize. So here there is basilar invagination. The whole world was doing transoral decompression or foramen magnum decompression. But listhesis is the issue, instability is the problem, stabilization is the treatment, realignment is the best form of treatment. But even if there is no realignment, that is not the issue. Stabilization is the issue. So there is no decompression. So this kind of thing has changed the whole world of craniovertebral junction. And I take big credit in changing the concepts. So this was 1999, where we said listhesis is the problem, basilar invagination is the cause, is secondary, instability is the issue, and stabilization is the treatment. Then we introduced this concept of central instability, where we said even when there is no atlantodental interval disturbance, it can be unstable. As you know, the whole world will do foramen magnum decompression for this, but this is unstable. You have to stabilize. There is no role for decompression in this situation. And in my view, which is completely clear, that decompression in this kind of unstable spine is a completely wrong operation. So here, if you see, even when there is no facetal malalignment, no atlantodental interval disturbance, presence of Chiari, presence of Syrinx are indicators of unstable atlantoaxial joint. This is the father, they are the children. You treat the father, the children will come in line in no time, and most importantly, the patient will remarkably recover. So Chiari malformation, syringomalia, basilar invagination, and so many other issues, Klippel-Feil anomaly, assimilation of atlas, C2-3 fusion, and all these things are secondary. They are naturally protective or adaptive and potentially or manifestly reversible. Not just craniovertebral junction problem, central or atlantoaxial instability can be the cause of cervical problems, OPLL, degenerative spine, and so many other issues, which I will talk a little bit. I'm going to brief you very quickly. So basilar invagination is not a pathology. It is secondary to unstable craniovertebral junction. Stabilization is the treatment, not decompression. So those who are in this business will clearly understand that these concepts were not there earlier. And these concepts are game changers in the craniovertebral junction. Both group A and group B need atlantoaxial stabilization. So here you see there is Chiari and Syrinx. There is little bit problem here, but these are secondary, these are protective, these are reversible, these are secondary to atlantoaxial instability. You stabilize, they disappear or reduce, and most importantly, as I mentioned, that patient will dramatically recover. So we said in 1998 that there is tight posterior fossa, but you see the folia are wide, the fourth ventricle is never compressed, and herniation. The problem is even when there is no fascicle malalignment, no problem here, you have to do C1, C2 fixation. This is basilar invagination is one child, Chiari is second child, syringomyelia is third child, and there can be more children of this father. Treat the father, and that is the treatment. Syringomyelia will reduce in 100% of cases. Problem is atlantoaxial instability. And we have got now several hundred patients where we have treated all kinds of Chiari, whether they are alone, whether they are with Syrinx, whether they are with basilar invagination, by atlantoaxial fixation. You see, there is no bone problem, nothing here, do fixation, and that is, in my view, there is no question that this is a complete revolution in a number of pathologies, but it has to be understood. And also it has to be performed. To do C1, C2 fixation in Chiari is not easy. There can be furious blood loss in the region of lateral gutters and extradural venous bleeding. So this is 388 cases experience, which we discussed several years ago. Now my experience is beyond 600. No question that Chiari is protective. Chiari is not a malformation, it is a formation. It is protective, and it is like an airbag, and it should not be, you don't remove the airbag. So this, you have to look at the facets. There is Chiari, you fix, the tonsil will go up, the syrinx will reduce. This is syringomyelia reduction, no problem here, little bit problem here, C1, C2 fixation. And as I have mentioned now, that we have got several hundred patients. Oh, I have no confusion. Maybe I will suggest, my dear friends, those who are watching me and those who will watch me later, that don't have confusion. This is the concept which is here to stay, and this is the future of treatment of Chiari and treatment of bone fusions. Bone fusions is a protective. Second, it is one of the other child of atlantoaxial instability. You see this bone fusion, don't start doing decompressions and all. This is unstable. You do fusion and you see the magic. So this bone fusion, difficult operation, this kind of fusion is not easy, but you can give this kind of smile. C2-3 fusion is not a primary event. It is secondary to atlantoaxial instability. You see in this case, just see carefully and quickly that there is compression here, but there is C2-3 fusion. So this is secondary. Don't think of compression. You do C1, C2 fixation. This compression is not the issue. Similarly, in this case, you see there is unstable, there is unstable, there is compression here, there is no compression here. What you have to do is C1, C2 stabilization. Like in this case, multiple bone fusions, clipal file, Chiari, Syrinx. Now don't start doing decompression and syringostomy. The issue is C1, C2 stabilization. Similarly, there is no compression, but there is C2, 3, 4 fusion. Here, this patient needs C1, C2 fixation. So you can imagine the implications of this problem. Bifid is also secondary in this article. If you read, it is secondary, it is protective, it is naturally adaptive and reversible. So when you see bifid, it is by automatically, it is C1, C2 fixation, even when there is no compression. When you see fusions, it is automatically C1, C2 fixation. Similarly, os odontoideum is secondary, it is protected. There is no need for decompression. There is no need for occipitocervical fixation. C1, C2 fixation is the treatment. Syringomyelia is a sister of basilar invagination and Chiari malformation. Sometimes this sister can be present alone, Sister is always secondary to atlantoaxial instability, direct dealing of syringomyelia. You can imagine the contribution. The whole world was doing syringostomy. You can just think about it, how big the contribution is that the whole world was doing syringostomy. We said it is a protective mechanism. Whole world was doing decompression for Chiari. Imagine the implication. We are saying it is a protective mechanism. So it has got here huge implication. This kind of syringomyelia without Chiari was called idiopathic Syrinx. But as I mentioned, this sister can be present without other brothers, and you have to do C1, C2, and there is a possibility of magical treatment. There is no question about it. Sometimes there is extra amount of fluid in the subarachnoid spaces. We call it external syringomyelia. This has also got great implication. I wish, because this thing is so important to understand, that this external syringomyelia can indicate unstable atlantoaxial joint. Long-standing musculoskeletal problems like short neck and torticollis, you do C1, C2 fixation, there can be a immediate post-operative reversal. So this short neck and all those short neck, short head, short spine are all hallmarks of basilar invagination. So you can create wonders. And I am proud to say that it has been my fortune to understand this. And I'm, of course, nobody can be final, nobody can talk like this. But I have, my journey of strength is going strength after strength, and I'm getting these kind of, powerful patients. This kind of kyphoscoliosis can also be sometimes due to, short spine. When I say short neck, there can be torticollis. When I say short spine, there can be kyphoscoliosis. So imagine if I say the kyphoscoliosis many times can be due to craniovertebral junction, what big implication it has. You may not just imagine the beauty. So when you see bifid, it is C1, C2. When you see syringomyelia, it is C1, C2, even when there is no compression. So it is a huge revolution in this field. And also Hirayama disease, nobody knows what is the treatment of Hirayama disease. So this kind of extra medullary thing, this kind of curvature are all due to craniovertebral junction and subaxial instability. You can good new life. Nobody knew how to do Hirayama disease. So rotatory dislocation nowadays, we are doing dynamic head rotation scan. You see in this, there is no instability here, no instability here, but you do rotation, head rotation CT scan. You see the facet of C1 and facet of C2, how much they are malaligned, and this patient will need C1, C2 fixation, not any kind of decompression. So I have no hesitation to say that I have demolished transoral surgery from the books of spine, and I have also now, I am on the verge of demolishing foramen magnum from the books of spine and orthopedic spine and neurosurgical spine. Now I quickly go, I know it my whole life, I cannot summarize in 1 hour or 2 hours, but you can see the beauty of these important implications of this. Now, many people have followed my work on craniovertebral junction, and many of them are following, like for Chiari, many people are doing C1, C2 fixation in the world. Now, but not too many in spine surgery. Listen to this concept very quickly and rapidly. You can see other lectures, bigger lectures in other presentations on Neurosurgical TV. Compression is never primary. Compression indicates unstable spine. It is secondary to unstable spine. It is protective. It is reversible. And decompression is never the treatment. Huge statements to make, big, huge statements, and probably controversial for others, but not for me, because now I'm doing this for more than 15 years, no question, and big, huge, high-profile people have been treated by these kind of things. So all the muscles are focused on the facet. The disc is the powerhouse. The muscles are the movement of the powerhouse. This is the car tire, and this is like a petrol and muscle. All our muscles are focused on the facets, and when these muscles become weak due to disuse, abuse, or injury, there is some kind of facetal listhesis, and this listhesis at the facetal articulation, and this listhesis is the cause of vertical facetal listhesis. such a huge concept, and this cannot be identified on radiology, and this will be certainly ignored. And osteophytes and all these things are secondary, and all these things are protective. Like in craniovertebral junction, there is central instability. So these kind of anterior surgery was a very common thing for me, decompression, and as I mentioned to you earlier. And these kind of screws were very commonly in my department. But then we changed for last 20 years. This article I had written several years ago, where we said for the first time, this was written 15 years ago on the basis of 108 cases. You can imagine for so many years I have been doing this. So instability in degenerative craniovertebral junction. So instability was the major thing, not compression. Now you see this beautiful picture which I like to show on all occasions: reduction in the joint space, buckling of these ligaments, osteophyte formation are not primary, they are secondary to unstable spine. They indicate instability, like osteophyte formation here, and osteophyte formation and bone fusions. This osteophyte here, this osteophyte in the apical ligament in front, they indicate unstable spine. They are secondary, they are protective, they are naturally adaptive. You should not decompress, you stabilize and realign. Even if realignment is incomplete, that is not the issue, but stabilization is the treatment. So when we see this, you see the reduction in the joint space, osteophyte formation, retroodontoid pseudotumor, the whole world was doing. Imagine the beauty of this concept and how much it has changed the subject of spine. The whole world was doing transoral decompression. For the first time, 20 or 25 years ago, we said that this is due to unstable spine. This is like an osteophyte. It is atlantoaxial instability you have to do. And believe me, now the many people in the world are following this concept. It has completely revolutionized the subject. So the first paper of mine was published 21 years ago on this subject in Japanese journal, and now many people in the world are following this concept. Retroodontoid cyst, we said for the first time that this is not a primary event, it is secondary to unstable spine. You stabilize, the cyst will disappear. Imagine such a great concept. And I also sometimes think about this kind of bone here, this kind of retroodont, this is dynamic process. When flexion extension goes in and out, the problem is not this dynamicity, problem is not this compression, problem is unstable joint, you have to stabilize. So I have to recommend this article for you to read, and beautiful concepts on retroodontoid pseudotumor and PANAS. PANAS, the whole world was doing transoral decompression. We said this is due to vertical instability. This is buckling of the ligament. You stabilize, the PANAS can disappear as early as in the immediate postoperative period. We described C1, C2 instability, but nobody in the world had described subaxial facetal instability. Now I will show you one magic. Reduction in the joint space, bulging of this disc, osteophyte formation are not primary. Don't think about this as a problem. They are secondary, they are protective, they are reversible, they indicate unstable joints. So these kind of bone formation and this kind of bone formation are secondary. This kind of bone formation, this kind of osteophyte formation indicate unstable spine. They do not, the concept was when these bones are formed, they are more stable than normal, which is a completely wrong concept. Bone formation and bone, these are unstable formations. So this kind of bulging, these kind of osteophytes are all secondary. These kind of beautiful osteophytes are beautiful natural event. Now I will show you one technique. And I have to tell you, one of the greatest athletes of all times in the world was treated recently by this technique. I don't want to name this athlete because of the confidentiality issues, but this kind of, you see, there is, I said, there is facetal listhesis, open the joint, distract the facet, introduce this spacer. And there is no need for decompression. So the world's #1 athlete was treated by this technique. You see this bulging of this disc, bulging of ligamentum flavum. You don't have to worry about this. You have to worry about unstable spine. So we had introduced multi-level spacers, and this was published as cover page of Journal of Neurosurgery in 2011. Similar concept for lumbar canal stenosis we introduced. We call them vertical instability, introduced these spacers, and this was published in Journal of Neurosurgery. So you have to, you see, whatever statements I am making are revolutionary. They are complete game changers, where we are saying for stenosis, you don't have to decompress. This is the spacers which we introduce. Then we changed our concept. We said that there is no need for decompression, and even primary decompression or secondary decompression by spacers. Only fixation is the treatment for cervical spondylosis and lumbar treatment. In 2020, we introduced this article, complete revolution. Nobody can challenge this revolution, I am telling you. But believe me, this is the future. And many people of my own students, who are, some of them are on the screen, they follow these concepts. Muscle weakness related spinal instability is the cause of spinal degeneration. And spinal stabilization is the treatment, not decompression. So you please read this paper, and then after this 220, we have got several patients like this, where this kind of multiple cord compression, the whole world treats by decompression. What we have done is only fixation. So this kind of only fixation, no decompression, and you see the whole thing will reverse after a period of time. And I have got several examples. So I don't need to be, if somebody wants to criticize or argue, that is their own problem. I am saying root compression, cord compression, don't think about it. You think about unstable spine and treat. So we should look at degenerative spine in a different perspective. Instability is the symptom and stabilization is the treatment. Most important issue in spinal degeneration is this is a 2-level compression. I have done 4-level or 5-level fixation. Why for 2-level, 4-level? So that is the real issue in spinal degeneration, which we have to understand why upper levels, and then you talk about adjacent segment disease and all those things. If you identify the segment properly before, you will not need adjacent segment problem. So this is 3-level compression, 5 or 6-level fixation. So this is a beautiful thing. Another beautiful thing that we introduced, this is my spine, this is my book of spine. We said for the first time that in degenerative spine, there can be several occasions where there is atlantoaxial instability. So there is multi-level, there is no compression here, but the facets are unstable. So in this kind of thing, that you have to include atlantoaxial joint in the fixation construct, and you have the potential of creating a magic. When the patient is severely disabled, on a wheelchair, on a trolley, more often than not, no compression here, they need C1, C2, and subaxial fixation. In not decompression is not the thing. Another beautiful revolution that we introduced, believe me, my friend, complete game changer in the treatment of lumbar canal stenosis. This was published in Neurosurgical Focus. You read the title, Lumbar Canal Stenosis, Analyzing the Role of Stabilization and Futility of Decompression as Treatment. So this kind of lumbar canal stenosis, I have treated only by fixation, no decompression, and you have to only believe me, or you have to come and see the patients here. Remarkable. So we should not call it stenosis, we should call it unstable spine. The question is whether we should remove the osteophytes. The whole world of spine surgery removes the osteophyte, or they do laminectomy to make space for the osteophyte. So what we said is that there is no need to remove the osteophyte. You do fixation and these osteophytes will spontaneously disappear. You see this osteophyte, they have disappeared here, and I have not done any kind of laminectomy. I have not done any kind of anterior surgery, and that is, in my view, a big revolution. You see, this is retroodontoid, huge cyst, huge tumor, and multiple level osteophytes. And this is after a period. This has also disappeared. These have also disappeared. Little bit is remaining here. Basically, retroodontoid and subaxial osteophytes are the children of the same origin, and that is instability. Deformities, you know how the deformities are treated by corpectomy and all those things. So we said that these are secondary to unstable spine. This needs C1, C2 fixation. This needs subaxial fixation. This needs this kind of, so various kinds of fixation are required. So this, when you see, is not for decompression. it is for stabilization. Another very probably a controversial issue is disc. We have said, and you must read this article beautifully, that disc is a mother. Mother can never go wrong. When you lift up very heavy weights and break the ligaments, disc herniates and causes pain. That pain reduces the activity, and this is disc herniation is secondary to unstable spine. You stabilize prolapsed disc, and you have to only stabilize. There is no need to do decompression. I am nowadays with herniated in extruded disc, maybe I sometimes remove the extruded disc, but otherwise it is not necessary. So this kind of disc herniation, the whole world will do anterior surgery or whatever ACDF and whatever, but I have not done any anterior surgery, only fixation. You see the disc has disappeared after a few months. And whatever I am saying is published heavily. This is published in World Neurosurgery. Similarly, lumbar radiculopathy, this kind of disc herniation, I think there's no question. You just stabilize these two segments and you will find a complete world of difference. Ossification of posterior longitudinal ligament, OPLL, is another difficult chapter in spine surgery. I have said that OPLL is secondary to unstable spine and only stabilization is the treatment. You can imagine, just think about it. What a radical change in the concept. What a radical change in the thinking process, that you have to do only fixation. There is no need for decompression. You see, you will be struggling with decompression from front or from behind. Don't worry about this compression, fixation, and see the magic. And atlantoaxial instability is very frequently associated with OPLL, and you have to include atlantoaxial joint in the fixation construct. And no decompression from front, no decompression from behind, and the only answer is a magical clinical outcome. See, when I use these words magical and all those things, they look very inflated and very egoistic and very hyper statement. But I'm proud to say that you have to experience this beautiful clinical outcome if you have done the correct levels. If you have not done correct levels, maybe you don't get. So atlantoaxial and subaxial fixation, it can revolutionize the treatment. So these decompressive laminectomies can go in the history books. There is no question. So this is my book of spine surgery. I hope there are some beautiful lessons for the world to understand, and some beautiful lessons for the people to follow and maybe not follow, but whatever said and done, I have published all these things on a basis of very big experience. And I hope and I wish that people take some of these things in right perspective. Thank you very much, my dear friends.
Atul,
Harshad.
yes, you have taken us to another journey of spine, right from C1 to S pi, whole spine, and you made it very, very understandable to everyone how the disk degeneration is not causing a compression and it is a divine disk which is helping the patient rather than harming the patient by giving various analogies, right from aeroplane to various animals and how their bones work. I must say you are a great thinker. Otherwise, it will not come. It's not only the science. There is a lot of philosophy in the involved into it, and we are all convinced now. And even in my own practice, when I have done ACDF and patient didn't improve, when we did posteriorly and patient showed a very good result. So there is no doubt about it. And many people in the world have started doing this. And it takes time to get it into the minds of people, but revolutionize. There is no question about the revolutionize. And wonderful, not only the brain but the spine, and especially the C1 C2 what you are showing, and we have seen you operating C1 C2, and I cannot forget the 10 months old child you were operating, and I was with you in the Lilavati, and you finished in 30 minutes, 35 minutes. Wonderfully done, that child. And it's not a joke to do. And you have a great experience, great expertise, and great dedication, I must say. And just one question when you were talking about the syringomyelia, I had clipped a pica aneurysm. and a young boy, and a few years ago, and now he has developed the secondary syrinx. We have gone through the posterior fossa, and what is happening? There is a trapped fourth ventricle which is communicating with the syrinx. Do you think it is again an instability which we have created?
It is at least not a pathology, I am saying.
Yeah,
Syringomyelia can
yeah,
never be a pathology. It is always
yeah,
secondary. So we have to
yeah,
first identify the cause and treat the cause. And more
yeah.
important is when you have done posterior fossa decompression, maybe some instability has occurred. I
Yes.
will like to see more of this. And if it has occurred, it will need stabilization. And that is the answer, Harshad. There is no doubt about it.
Yeah, when you were talking about syringe, it just reminded me. Recently, I'd seen that patient again. The aneurysm is cured, everything is cured, but the problem is this new thing is developed. It's an acquired syrinx. It is an instability.
Okay, okay.
Right, 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 right. Takashi is there. Is looking forward to talk to you. Our good
Okay.
friend Takashi is from Japan. At this time is waiting to speak to you. Yes,
Thank
Thank you.
you,
Takashi, go
doctor.
on.
Welcome,
Thank you.
Takashi. Welcome.
Welcome again. A long time no see. I'm Dr. Ko from Tokyo, Showa University, Tokyo, Japan. Dr. Goel with a nice presentation and very good opportunity to review many papers we experience. In Japan, also AAD or Chiari is recognized as a radiologically, but a function is not recognized yet. Only some other neurosurgeons, orthopedic surgeons, there are some discussions, there is some conflicts. So to solve this problem, your paper, your information is very informative. Thank you for lectures. Thank you.
Thank you, Takashi. Thank you. And best wishes to you.
Wonderful talk. Wonderful.
That's it.
What he says is very correct. Very correct. And we rarely see nowadays transodontoid excision, transoral odontoid excision. You remember those days when we used to go to Ellen Crockett to learn it.
Okay. Okay, okay.
Okay, Naveen, I guess has a question. Naveen Kirti, he's a med student from Mumbai. Go ahead, Naveen. You gotta unmute.
Uh,
unmute.
yeah. Good evening, Dr. Goel. Actually, I've been a huge fan of yours. I'm Naveen Kirti. I'm from Maimer Medical College. I also a colleague of mine, Ojas Joshi. You operated on his mother, and he always tells me how great of a doctor you are. And I've been following your work since the first year of med school that I've joined. And the Goel facet spacer that you have brought up, how did you even think of it? I mean, you are an innovator and a surgeon at the same time. I mean, it's just so inspiring. Thank you, doctor.
No, anybody can think about such things. You know, can imagine this C1, C2 technique I described when I was your age, 27 years old. Or maybe you are younger than that. But 27, I describe C1, C2. It is on the basis of very intense anatomical work on the cadavers and all those things. This in 1987, 88, you know, no neurosurgeon or spine surgeon knew what screws are. Nobody knew screws. Nobody knew plates and nobody knew facets. So this, what we introduced at that time was absolute beauty. And when I sometimes think about it, you know, some lumbar spine fixation had started being introduced at that time. But basically, nobody knew these kind of techniques and all those things. So we introduced. So it is a young mind. You don't think that you cannot do. I look forward to you introducing some beautiful work and come into neurosurgery. This is a great subject, and let us see how we go further. Okay?
Thank you. Thank you so much, Dr. Goel.
Okay, okay.
Naveen wants to do a observership with you, Atul.
Yeah.
He's the man after your own heart. He's done a lot of some publishing already as a student. Can you
I'm an
believe that?
aspiring neurosurgeon scientist, Dr. Goel, actually. And
Okay. So
I've worked in Melbourne Medical School in the neurodynamics lab along with neurosurgeons to develop an EEG clamp. Yeah. So,
Okay, you'll be hearing from
yeah.
him. Okay, any more questions? More questions? Don't be afraid. This is a golden opportunity. Mohammed, do you have a question?
Yes, of course.
Go ahead.
Always.
Go ahead. Go
Mohammed,
ahead.
how
It's
many
all
times?
yours.
Yeah, I just want to say that the word revolution is very good word for this topic actually. And the word magic, I always feel proud about it. So you have to keep saying it because it's really magic. Yeah, I've seen it myself. So I've seen it in India, I've seen it here. I'm doing it here, so it's real magic. Thank you so much. I would ask a good question. Do you consider C1, C2 in OPLL depends on the patient clinical how does if the patient is walking or not, or it depends on only radiologic?
No, not radiology. Many of these patients of OPLL have atlantoaxial dislocation is more often present than not. So actually, if there is high OPLL, then of course you have to do C1, C2. But as you know, I have described a new technique of C1, C2 by avoiding putting screw in C1. I do C2, 3 fusion and cut the spinous process of C2. So that is an alternative technique where I am retaining the rotatory movements of the neck and I'm stabilizing the C1, C2. So that is another technique. But in many of these OPLL cases, more often than not, C1, C2 is the issue.
Thank you so much.
So thank you, my dear friends, and thank you for joining me. And thank you, John, for being with me for so many years, for more than several hundred lectures on this site. So, and you know what, you can get all these lectures. He has made a kind of a link now, John.
Yes, I
And
put the link in the chat of all your webcasts you've done with us.
so that those link can be used, then can see in this is just a summary of my work.
Yes,
But
yes.
individually, I have given several presentations on Chiari, only on Chiari, only on OPLL, only on disk. So you can see these things on that link. So thank you very much, my dear John, and hope to see you next time with some more medals on my chest.
A true pleasure. Thank you, King.
Thank you. And
Atul,
bye-bye.
create some space. Atul, create some space on your crown so
That's
that
right.
some more
That's
feathers
right.
can be added.
That's right.
Thank you and bye-bye. Bye-bye.
Okay,
Bye bye.
bye-bye.
Good night. Bye.
Thank
Thank
you.
you.
Thank you.
Thank you, John. Thank you.
Abby, hang around, hang around. Abby, we have a guy here that wants to help you.
Who? Hi, Dr. Takashi.
You need
Yeah.
him. Naveen lives in Mumbai. He's already done research papers, and I told him Abby needs help. She needs help arranging stuff. You know how you have a lot of work to do and for the king, arranging stuff and researching stuff. He can help you, right, Naveen?
Yes, Dr. Bennett. And hello, Dr. Abhi. I'm Naveen this side. I'm from Mumbai, actually. I'm a third year med student. And yeah, and I
Which
would like to
hospital?
contribute to any
Which
Maimer
medical?
Medical College.
Which one?
Maimer Medical College. Maimer, Maharashtra Institute of Medical Education and Research. It's in
Where
Talegaon.
is it? Talegaon.
In
Okay.
Talegaon, in Pune. Yeah.
Okay.
So I
Okay.
would
He
love to
wants to be
contribute
your
in any
aide.
capacity.
Okay, sure. You
Okay.
can take my contact from John. Yeah.
Yeah, great, Abby.
Thank you so much,
I think
Dr.
he'd help you a lot. Yeah, I know you're
Yeah.
hard work.
Good to see you, Abby. It's good to see you.
Hi, Mohammed. How are you?
I'm doing good, right? Thank you so much. You're looking great, as always.
Thank you.
She's happy.
Okay. Okay, John. So
Hey,
now
thanks.
we will
Thank
Okay.
you,
see you in
John.
the
Bye,
next.
Thank
everybody.
you. Thank you, Dr. Abhi.
Thanks, Harshad. Excellent intro.
Bye.
Bye-bye.
Bye. 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 Thank you.
Bye.
Bye,
Takashi.
Takashi. Bye.
Bye. Bye.
Hey,
Yeah. Thank
Takashi,
you.
Bye.
we gotta do a Japanese
Thank
TV.
you,
We
everyone
gotta
from
do a
Zimbabwe.
Yeah.
Thank you.
We are eager to do. We are eager to proceed. Thank you.
Okay. Yeah, we gotta do that. If anybody that wants to present anything in neurosurgery in Japanese, I'd love to
Yes.
do it. I'd love to do it. Anything.
There are many Japanese. So yeah, they are very interested. So
Yeah, in Japanese. In Japanese. to some people that would be valuable, you know,
Yeah.
for their associates to see them on live too, YouTube. They would like, I think they would like that. Some would like it because, as you know, some don't like video.
Yeah. So,
So you've been real busy, Takashi?
yeah, I've been busy, but these days, so I became a little bit free. So I'm available,
Good.
and I would attend the Zoom webinar as possible.
Oh, okay. Okay, very good. We have one in Spanish on Saturday on interventional radiology. I don't know if you're interested in that.
Yeah, yeah.
Neurointerventional for stroke. You're mostly tumor though, right?
Yeah.
Okay. Very good. Very good. That went well. He always gives a great lecture. Man, oh man. Really, really well put together. To me, I'm not a neurosurgeon, but I understand it. It's not a complicated thing. And you know, when I was an ER physician, Takashi, or that's what I was for 15 years, but one thing that always puzzled me when back surgeons operated was they're taking out the lamina. That's the strength of the structure. You're taking away. I mean, just on a simple way of thinking for me, I would think you're taking away from the stability of the spine and the strength of the spine by taking the lamina out. Are they still doing the laminectomies and taking out discs and stuff? They're still doing that, laminectomies, where they take out the lamina? They are? Okay. Okay. You're tired, Takashi. You're about to fall asleep. Go take a nap. Okay.
See
Very good.
Yeah.
See, Takashi has a banner. He works for us. You see that? You see that, Naveen?
Yeah, yes. Hello, Dr. Takashi.
He's
Naveen
a
this side.
Japanese chapter.
Yeah, Japanese chapter. Thinking of beginning the Japanese chapter of Neurosurgical TV. So,
No, it'd be Japanese. Let me get the screen. It would be Japanese TV.
yeah, Japanese TV.
Yeah, let
because
me
the
share
Kyoto.
it.
Yes.
Let me share it. Hold on. I got it. Let me share it now. Hold on, I got it. There you go. Okay. You see the screen there?
Yeah. Yeah.
Yes, Dr. Bennett.
Smart brain surgery system.
So that's actually a name, neurosurgery in Japanese.
Yes.
And
Yes.
and a TV, I was able to buy that because no one thought to combine the two. But my position is that everybody knows what a TV is. If in Japan, China, wherever you go, if you say to someone on the street, TV, they'll know it, what it means, right, Takashi? People know what the word TV is, Naveen.
TV is okay.
Yes,
TV is TV
yes,
in
Dr.
Japan also.
It's
TV
the
is very
same in
universal.
China, all over the world, TV. That's how you can communicate with anybody. TV, I want a TV. They'll say, oh yeah, you go here.
Yeah. Yes, Dr. Bennett.
But
It's universal.
nowadays, the TV is more than the television. It's the internet. Can be TV. But anyways, so just let me know anytime you're ready, Takashi.
Yeah.
Okay, Naveen, you got to meet the king.
Yeah. Yes. All because of you, Dr. Bennett. All correct.
Well, you know your background. You've done a lot of research. I mean, for a med student. So he really, just like I'm sure he was that way in med school too, because he's probably the most published neurosurgeon in the world, as you probably know.
Yes, Dr. Bennett. I just saw
Yeah.
his publications. There's so many.
So you can appeal to him in that respect. You have not only neurosurgery in common, you have publishing. As you
Yes,
know, most neurosurgeons don't like it. I know I wouldn't like to publish, you know, and you can relate to him. And as far as a way for you to get to know them better, I think
yes,
you need to volunteer with Abby. Help her
yeah,
out.
yeah.
She needs help.
Yes, Dr. Bennett.
Yeah,
Yes, Dr.
you go meet
If you
her.
could share me the contact details, Dr. Bennett, that would be
Yeah, I'm going to give
very helpful.
you her WhatsApp.
Yes,
Yeah, you basically need to help her out. She needs help. She's
yeah,
busy. I mean,
yes,
she's a
yes, Dr.
busy,
Bennett. I'll do
yeah,
that.
she's a busy neurosurgeon. I mean, obviously, Dr. Goel speaks in a lot of places. He probably gets confused, a lot of details, time difference, and all that stuff. So I think she probably would appreciate help there.
Yes, 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 Dr. Bennett.
And just you being around that scene, you'd be inside
Yes,
the makings of
yes, Dr.
because he has, as you probably know, a big group of people that follow him around the hospital.
Yeah, yeah, yeah,
But
yeah,
if
yeah.
you if you were an assistant, you would be distinguished in that respect.
Yes,
So, okay,
yes,
gentlemen,
yes,
you
Dr.
guys
Bennett.
have a
You're
great
completely right.
day.
Thank you.
Thanks for coming, Takashi. I hope to hear from
Thank you
you.
so much, Dr. Bennett.
Yeah.
Yeah,
Bye-bye.
Thank you.
thank you, Dr.
Okay.